Welcome to the Deep Dive. Today, we're getting into some really crucial guidance from the Society for Vascular Surgery. We're looking at their latest practice guidelines on occlusive disease of the lower extremities.
That's right.
And this isn't just a quick summary. We're really going to unpack the core recommendations, focusing specifically on managing asymptomatic disease and intermittent claudication.
Yeah, and our mission here really is to give you a structured, evidence-based understanding. I mean, these guidelines pull together a huge amount of research, so I want to distill that into, actionable insights for clinical practice. We'll hit the epidemiology, diagnosis, and the non-interventional management stuff, trying to get at the why behind it all.
Exactly. We're drawing directly from that big SVS document, Management of Asymptomatic Disease and Claudication, highlighting the key takeaways, maybe some surprising bits, and really helping you master these guidelines. So let's dive in. Development and scope of the guidelines. Okay, first off, let's talk about how these guidelines actually come together, because it's quite a rigorous process, right?
Oh, absolutely. The SVS Lower Extremity Guidelines Committee, they put in a significant effort. They mapped out the diagnostic and management choices for peripheral arterial disease, PAD, stage by stage.
Right.
And given how broad PAD is, this specific document narrows the focus. It zooms in on evaluating and managing asymptomatic disease and intermittent claudication.
So not critical limb ischemia.
Exactly. It's important to remember separate guidelines are coming for critical limb ischemia, or CLI. That's its own beast. For this one, the committee developed key questions, condensed them into topics, and commissioned systematic evidence reviews.
So the evidence base is published alongside.
Precisely. It provides that solid foundation for every recommendation. You can see the work that went into it.
And the methodology itself sounds pretty thorough, not just one person writing it up.
No, not at all. It was very collaborative. Members drafted sections, then the whole writing group reviewed and revised. It was iterative, consensus-driven. And these guidelines are quite specific, too, focusing on treatments available right now in the United States. Plus, they had a dedicated methodologist rate the evidence quality and recommendation strength.
Full transparency, too, with the conflict of interest disclosures.
Yes, absolutely. Standard SVS policy, but crucial for trust and transparency. It really speaks to the thoroughness. 2, epidemiology and risk factors of peripheral arterial disease, PA.
Okay, let's shift gears a bit. Talk about the burden of PEA. How widespread is this, both here and globally?
Well, globally, the exact numbers are a bit hard to pin down, but here in the U.S., estimates suggest maybe 8 to 12 million Americans are affected, which is already a substantial number.
Yeah, quite a few.
But if you look worldwide, a big meta-analysis covering 34 studies gave a conservative estimate of over 202 million people with PAD globally.
Wow, 202 million.
And what's really striking is how fast it grew. In the first decade of this century, the prevalence jumped by about 23.5%.
Globally?
Globally, yeah. The biggest jump, almost 29%, was in low and middle-income countries. But even high-income countries saw a 13% increase, so it's rising everywhere.
Interesting. And any difference between men and women?
It varies. In high-income countries, it's pretty equal between men and women, but in low and middle-income countries, it's actually higher in women, particularly younger women.
So what's behind this increase? What are the main culprits?
It really comes down to a few key things. Consistently identified across all nations, increased longevity, people are living longer, smoking a huge factor, and diabetes, the ongoing epidemic.
Right.
And as populations keep aging and, diabetes, hypertension, obesity rates continue to climb, the expectation is clear. PAD prevalence is going to keep rising, both here and globally.
Which brings us to the cost. I imagine the economic impact is pretty massive.
Oh, astronomical. And the data we have is likely an underestimate. Back in 2001, U.S. Medicare spent over $4.3 billion just on PAD-related treatments. That was like 13% of all their spending for PA patients that year.
And that was over 2 decades ago.
Exactly. By 2004, the REACH registry estimated total vascular-related hospitalization costs in the U.S. hit $21 billion, most of that tied to revascularizations. And given how much more common invasive treatments have become since then, you can bet the current costs are way, way higher. It's a huge economic burden.
Before we jump into diagnosis, let's just quickly clarify definitions. How do these guidelines define asymptomatic versus symptomatic PA?
Good point. So for this document, asymptomatic disease is just that. Evidence of underlying PA, like an abnormal ABI, but without any symptoms.
Okay.
Symptomatic PA then generally shows up as either intermittent claudication or, more severely, with signs of limb-threatening ischemia, what we call critical limb ischemia, CLI.
But this guideline focuses on
Intermittent claudication, or IC. And they define IC very precisely. It's a reproducible discomfort in a specific muscle group, usually the calf, but could be thigh or buttock, that's induced by exercise and relieved with rest, always caused by an arterial blockage upstream from that muscle. 3. Diagnosis of peripheral arterial disease, PAD.
Okay, diagnosis. What's the absolute first-line test? The cornerstone.
Without a doubt, it's measuring the Ankle Brachial Index, the ABI.
Right.
And an ABI of 0.90 or less is the key threshold. It's shown really high sensitivity and specificity for PAD when you compare it to invasive arteriography, the sort of traditional gold standard.
Are there other non-invasive tests that are useful?
Well, things like carotid intima media thickness or brachial artery flow-mediated dilation show some promise, but honestly, they aren't widely used. They need specialized gear and expertise, so ABI remains king for initial diagnosis.
And I recall hearing the ABI isn't just about the legs. It tells you about overall cardiovascular risk, too.
Yes, that's absolutely critical. An ABI less than 0.90 or actually greater than 1.40, which suggests stiff, calcified arteries that don't compress well, both of those signal an increased risk of major cardiovascular events, heart attack, stroke.
So it's a systemic red flag.
Exactly. It's more than just a leg problem.
Okay. So given its diagnostic power and this prognostic value, should we just be screening everyone with an ABI? Broad population screening.
Well, that's where things get interesting and, frankly, controversial. There's ongoing debate.
Right.
The U.S. Preventive Services Task Force looked at this and basically said, we don't have enough evidence. They gave ABI screening an indeterminate rating, couldn't really weigh the benefits versus harms for the general asymptomatic population.
And what did the SVS analysis find?
It kind of echoed that. Their meta-analysis suggested that while ABI testing might add a little bit to predicting cardiovascular risk, the current evidence just doesn't support screening everybody who's asymptomatic.
But maybe certain groups?
That's the potential next step. Future research might pinpoint specific high-risk groups who could benefit. Maybe people over 70, smokers, diabetics, or those with known heart disease, but no leg symptoms. Screening them might trigger more aggressive medical treatment.
But for now,
those subgroups aren't well defined enough, so broad population screening isn't recommended.
okay, so let's say a patient comes in, classic claudication symptoms, and their ABI is abnormal. What's the immediate next thought process? What else could it be?
Right, ruling out the mimics is essential because other things can feel a lot like claudication.
Like what?
Things like chronic compartment syndrome, venous claudication, spinal stenosis, sometimes called neurogenic claudication, even foot or ankle arthritis.
How do you tell them apart?
It really comes down to the history and physical, meticulously characterizing the symptoms. Is it truly reproducible with a certain amount of walking? Does it resolve quickly with rest? That's classic arterial claudication. Spinal stenosis pain, for example, often feels better when bending forward like leaning on a shopping cart, and worse when standing straight. Chronic compartment syndrome pain comes on after more intense exercise and takes much longer to go away.
So a really detailed history is key.
Absolutely crucial. Paying attention to provoking factors, relieving factors, the exact nature of the pain. Most alternatives can be sorted out just with a good history and physical exam.
And beyond the history, what about objective findings on exam or basic testing?
Well, the physical exam is obviously the cornerstone, looking for those classic signs. Weak or absent pulses distally, maybe loss of hair on the toes or feet, dry skin. In advanced cases, maybe skin breakdown or ulcers.
Right.
Quantitatively, non-invasive vascular testing is key. Beyond the resting ABI, if you get a really high ABI, say 1.4 or more, suggesting calcification.
Then the ABI isn't reliable.
Exactly. Arteries are too stiff to compress properly. In that case, the toe brachial index, or TBI, becomes incredibly useful. Digital arteries often aren't calcified. A TBI of 0.70 or less is generally considered indicative of significant arterial insufficiency.
Okay. And what about segmental pressures, or PVRs?
Those can add more detail, yeah. Segmental pressures and pulse volume recordings can help quantify the perfusion deficit more precisely and even help localize where the blockage might be. Not always needed, but definitely part of the toolkit.
What if the resting ABI is normal, or maybe borderline, but the patient's story just screams claudication?
That's where the exercise ABI comes in. It's extremely helpful in those situations.
How does that work?
Typically, the patient walks on a treadmill using a standardized protocol set speed, maybe a slight incline for up to 5 minutes, or until their symptoms stop them. You note when the pain starts.
And then measure the ABI again.
Immediately after they stop walking, yes. You calculate the post-exercise ABI. A significant drop, say, down to 0.90 or less, or maybe a 20% drop from baseline, or a drop of 30 millimeters of mercury plus a slow recovery time, like taking more than 3 minutes for the pressure to come back up. That strongly suggests a hemodynamically significant blockage that only shows up under stress.
Okay, that makes sense. So when do we escalate to things like CT angiography, MRA, or even contrast arteriography?
That's a critical point. These advanced imaging modalities, arterial duplex, CTA, MRA, contrast arteriography, they provide anatomical detail. But the guidelines are clear. Grade 1B evidence. These are recommended only for symptomatic patients where you're actively considering revascularization.
So not just for diagnosis.
No. If someone has asymptomatic PAD or even claudication, but they aren't a candidate for an intervention or don't want one, then the costs and potential risks, contract allergies, radiation, kidney injury of these anatomical studies generally aren't justified. It's a risk-benefit calculation.
Okay, let's try to pull these diagnostic threads together. A quick recap.
Sectional micro-recap. Diagnosis, sure. So the ABI is your frontline non-invasive tool. Less than 8A9 here is the key number. Broad screening of everyone, not supported yet, but maybe targeted screening in high-risk folks down the line. A detailed history and physical. Absolutely crucial to rule out mimics like spinal stenosis. If the ABI is high due to calcification, think toe brachial index. If the resting ABI is normal but symptoms are suspicious, use an exercise ABI. And remember, advanced anatomical imaging is reserved only for patients potentially heading towards revascularization.
Perfect. Let's put that into practice. Here's a quick case for you. 72-year-old male, exertional calf pain, resolves with rest. Classic story. Resting ABI is 0.95 bilaterally. Ex-smoker, controlled hypertension. What's the most appropriate next diagnostic step? Is it A, immediate CTA, B, refer for supervised exercise, C, perform an exercise ABI, or D, prescribe celestazole?
Okay, classic symptoms, but that resting ABI is just borderline normal, 0.95.
Right.
So A, immediate CTA. No, imaging isn't warranted yet. B, supervised exercise. That's a treatment, not the next diagnostic step. D, celestazole. Premature without a confirmed diagnosis of hemodynamically significant PAD, so it has to be C. Perform an exercise ankle brachial index.
Exactly. Grade 1A recommendation for this scenario. You need to unmask that potential obstruction with stress testing. IV, management of asymptomatic peripheral arterial disease, PAD. All right, let's move on to managing those patients who have PAD based on an ABI maybe, but have absolutely no symptoms. Asymptomatic PAD. Given we know it's a marker for higher cardiovascular risk, what's the core strategy? Do we intervene?
That's a key distinction. Because it's asymptomatic, the primary management is not intervention on the legs. It's fundamentally directed at aggressive risk factor modification. Think of it as treating systemic atherosclerosis.
Okay, so same strategies as for someone with known coronary disease, for example.
Pretty much, yes. Accepted preventive strategies for atherosclerosis are definitely appropriate. Now, some drugs used for symptomatic PAD have been tried here, but honestly, the benefit specifically for asymptomatic PAD patients without other major risk factors isn't always crystal clear or still needs verification. But the risk factor modification, that's paramount.
So what are the absolute non-negotiables? The top priorities?
Smoking cessation. Full stop. For any asymptomatic PAD patient who uses tobacco, comprehensive, multidisciplinary smoking cessation support is a grade 1A recommendation. The highest level. You have to be relentless about it.
Makes sense. What else?
Education is maybe less emphasized, but still crucial, educating these patients about the signs and symptoms of PAD progression, what claudication feels like, what critical limb ischemia looks like, so they know when to seek help if things change. It's an ungraded recommendation, but really valuable.
What about medications? Specifically statins. Should everyone with asymptomatic PAD be on one?
That's a bit nuanced. We know from big studies like the heart protection study that statins are protective in people with PAD overall, reducing mortality cardiovascular events.
Right.
But that study didn't specifically include only asymptomatic PAD patients, unless they also had other things like diabetes, hypertension, or known heart or brain vascular disease.
Okay.
So while statins have been linked to better leg function, it wasn't just about lipid lowering. Right now, the benefit of statins for someone with only asymptomatic PAD, no other cardiovascular disease, no diabetes, no hypertension, that benefit is less clear.
So follow general lipid guidelines.
Essentially, yes. The recent guidelines focus on overall 10-year cardiovascular risk. If that risk is elevated, generally above 7.5%, then statin therapy is usually considered, regardless of the asymptomatic PAD status alone.
Should we be actively looking for progression in these asymptomatic patients? Like doing yearly ABIs?
That's a really practical question, and the evidence isn't definitive. One small study did find that about a third of asymptomatic legs developed new lesions on duplex scans within a year, and about a quarter of patients developed claudication.
Hmm.
And critically, especially in diabetics, some patients can go straight from asymptomatic PAD to critical limb ischemia, skipping claudication entirely.
So surveillance seems reasonable.
It might be useful, especially in those higher risk patients diabetics, maybe those with a lower starting ABI. But the optimal frequency of repeat ABI testing, we don't really know for sure yet.
But what about invasive treatment? If you find worsening disease on imaging or ABI, even without symptoms?
This is the absolute key takeaway for asymptomatic PAD management, and it's a grade 1B recommendation. Invasive treatments, stents, bypass are generally indicated only for patients with symptoms,
Regardless of the test results.
regardless of hemodynamic measures or imaging findings showing PA. If the patient has no symptoms, intervention is strongly recommended against. The risks just outweigh the potential benefits in almost all cases. Exceptions are very rare, like fixing a failing graft or enabling another needed procedure.
Okay, so let's crystallize the management for asymptomatic PAB. Key message.
Sectional micro recap. Asymptomatic PA management. Right. Focus 1. Aggressive risk factor modification. Smoking cessation is number 1, grade 1A. Statins. Yes, if indicated by overall cardiovascular risk, but maybe not just for the asymptomatic PAD itself if there are no other risk factors. Surveillance. Maybe in high-risk folks, but optimal timing isn't set. And the big one, strongly discourage invasive treatment in the absence of symptoms.
Got it. Let's do another quick scenario. 65-year-old patient, just diagnosed with asymptomatic PAD, ABI is 0.80. No other heart disease history, no diabetes. But he's a current smoker. What's the most appropriate initial step? A, immediate CTA to plan revascularization. B, start a comprehensive smoking cessation program. C, prescribe aspirin and atorvastatin. Or D, just monitor with yearly ABIs.
Okay. Asymptomatic, ABI 0.80, smoker, but otherwise low risk based on the info given.
Yep.
Well, A, CTI is out, no intervention for asymptomatic disease. D, just monitoring isn't enough, he's smoking. C, aspirin and atorvastatin. Maybe eventually part of risk reduction, but the benefit of statin alone here is unclear, as we discussed. The most critical, highest yield initial step, grade 1A, is B, initiate comprehensive smoking cessation. That has to be tackled first and foremost.
Perfect. Tackling that grade 1A recommendation head on. V, non-interventional management of intermittent claudication. I see. Okay, now let's pivot to the patients who do have symptoms.
Yeah.
Intermittent claudication, probably the most common way PAD presents clinically. How do we approach managing this non-interventionally? Is there a one-size-fits-all?
Definitely not. The key word here is individualized. Patients with IC vary hugely in how severe their symptoms are, how much it impacts their daily life. Plus, they often have other things going on, heart or lung disease, arthritis, spine problems, obesity that can also limit their ability to walk and exercise. These things interact, so you really have to tailor the treatment based on their specific risk factors, how likely they are to stick with a plan, and what their own goals and values are.
What's something really crucial to address right at the beginning when someone is first diagnosed with claudication?
Patient education. It is absolutely paramount, and it goes beyond just explaining the disease.
How so?
You need to educate them about the long-term implications, mainly the increased cardiovascular risk. But just as importantly, you need to actively allay their fears about amputation.
Because that's often their biggest fear.
Exactly. They hear poor circulation and immediately think they're going to lose their leg. But the data is clear. While cardiovascular events are common, the risk of major amputation for someone with just claudication is actually very low, typically less than 1% per year. Framing it that way, this is more about your heart risk, and improving your walking than saving your leg right now can really help manage anxiety and set realistic goals.
So establish that framework first.
Always. Risk reduction, lifestyle changes, medical therapists, that foundation always comes before even thinking about invasive procedures for claudication.
Okay, let's break down those non-interventional strategies. Risk factor modification first. We already hit smoking cessation hard for asymptomatic PAD. Just as critical here.
If not more so. Grade 1A recommendation again. Continued smoking in PAD B patients is linked observationally to much higher rates of amputation, death, MI. Plus, it makes bypass grafts fail 2 to 3 times faster. Smoking cessation is non-negotiable.
What about lipids?
Again, crucial. PAD patients are automatically considered high or very high risk for cardiovascular events. Statins are indicated, grade 1A. The goal is lowering that cardiovascular risk, guided by estimating their 10-year risk rather than just chasing specific LDL numbers according to the latest guidelines.
Hypertension.
Mm-hmm.
And any specific concerns about meds like beta blockers?
Hypertension definitely needs treatment to reduce cardiovascular events. The link with PAD isn't quite as strong as smoking or diabetes, but it's there. And the beta blocker thing is mostly a myth. There's this old idea they worsen claudication, but there's no good evidence for that. So if a patient needs a beta blocker for their heart or blood pressure, use it. That's a grade 1B recommendation.
What about ACE inhibitors? I remember the HOPE study showed a benefit.
Yes, the HOPE study showed ramipril reduced cardiac events significantly in a large group that included thousands of PA patients. That was a big deal.
Wow.
But, and this is a really important update from the SVS, a subsequent trial specifically looking at ramipril versus placebo for improving walking performance in IC patients. It was retracted due to concerns about the data integrity.
Oh, wow. So no proven benefit for walking.
Correct. So, while ACE inhibitors are still vital for managing hypertension or heart failure, which are common in these patients, the direct evidence that they specifically improve claudication symptoms or walking ability, that's now considered unproven.
Good clarification. Antiplatelet therapy.
Hmm.
Aspirin. Clopidogrel.
Definitely recommend antiplatelet therapy. Aspirin, low dose 75 to 325 milligrams daily is grade 1A. Clopidogrel, 75 milligrams daily is a good alternative, especially if aspirin isn't tolerated. That's grade 1B.
Warfarin.
We suggest against using warfarin just for the PAD itself, just to reduce cardiovascular events or blockages. Grade 1C. Use it if there's another indication, like atrial fibrillation, of course.
And lastly, homocysteine. Some buzz around that.
Yeah, about 30% of PA patients have high homocysteine. And while folic acid and D12 vitamins can lower the levels, there's currently no data showing that lowering homocysteine actually translates into fewer heart attacks or strokes in PA patients.
So don't routinely supplement.
Correct. The guidelines suggest against using folic acid and B12 specifically as a treatment for IC. That's a grade 2C recommendation.
Okay, beyond these general risk modifications, are there drugs specifically approved to help the leg symptoms, the claudication itself?
Yes. In the U.S., there are currently 2 FDA-approved meds specifically for intermittent claudication, pentoxifylline and cilostazol.
How do they work?
Pentoxifylline, approved way back in '84, is thought to work by making blood less viscous, less sticky, and maybe inhibiting platelet aggregation a bit, theoretically improving flow.
Does it work well?
The results are modest, honestly. Early trials showed some benefit over placebo in walking distance, but it's often hard to predict who will respond, and it doesn't really improve the ABI numbers significantly. It's generally safe and cheap, but side effects like nausea can limit its use.
And cilostazol.
Cilostazol is a phosphodiesterase inhibitor. It does 2 main things. Suppresses platelet aggregation and acts as a direct vasodilator, opening up blood vessels. Patients often see improvement in walking within about 4 weeks.
Any major warnings with cilostazol?
Yes, a big one. It's contraindicated in patients with any level of heart failure because other drugs in its class were linked to increased mortality in advanced heart failure. So you have to be careful about that.
Does cilostazol work better than pentoxifylline?
There was a head-to-head trial, Dawson et al., that compared them directly. Cilostazol significantly increased maximal walking distance by about 54% on average. Pentoxifylline in that specific study was no better than placebo. So cilostazol generally seems more effective.
You mentioned a European drug.
Right, naftigerfural. Not available here, but interesting that the UK guidelines actually prefer it over both cilostazol and pentoxifylline. It seems to work by enhancing energy metabolism in ischemic muscle.
Any other options?
Yes.
Supplements.
Levocarnitine, which is available over the counter, has been studied. It helps provide energy substrate for muscle. Some trials showed modest improvement in walking, but it didn't seem to add anything beyond what exercise alone could do.
Okay, that leads us perfectly into the real cornerstone of non-interventional management.
Yeah.
Exercise therapy. How big a deal is this?
It's huge. Exercise therapy has been fundamental in IC management for over 40 years. It carries a level 1 recommendation from the American Heart Association. Multiple meta-analyses show it improves walking ability significantly, anywhere from 50% to even 200% improvement.
Wow, 50 to 200%.
Yes, substantial gains. And the benefits tend to last, maintained for up to 2 years in some studies. It can be truly transformative for patients.
But not everyone is a candidate.
Correct. You have to carefully evaluate patients first, make sure their other medical issues, heart problems, lung disease, severe arthritis, spinal stenosis are controlled enough that they can actually participate safely. Interestingly, many of the things that make someone a poor candidate for exercise also make them a poor candidate for surgery or stents.
So exercise first is usually appropriate.
Absolutely. For most patients with claudication, an initial dedicated attempt at exercise therapy is the right move before jumping to revascularization.
What makes an exercise program optimal for claudication? What are the key ingredients?
A classic meta-analysis really broke this down. The best results came from programs that lasted longer than 6 months, had sessions at least 3 times a week, lasted over 30 minutes each time, and crucially, used nearly maximal claudication pain as the endpoint for each walking interval.
So walk into the pain.
Yes, pushing to that point where the pain is near maximal, then resting, then repeating. That seems to be the key stimulus for adaptation. Walking itself was the best mode of exercise, and the program duration mattered too.
Does intensity matter? Or just walking to the point of pain?
Both can work. Low-intensity exercise can be effective if you do it for longer, getting similar total exercise exposure. But generally, using that nearly maximal pain endpoint seems to produce greater improvements in walking distance compared to just stopping when the pain first starts.
What about supervised versus home programs, especially with insurance coverage issues for supervised programs?
That's a really practical challenge. The evidence is pretty consistent. Structured, supervised exercise programs deliver superior outcomes compared to just telling someone to walk on their own at home.
Why is that?
Mostly compliance and adherence. Having that structure, the supervision, the group dynamic, maybe it keeps people motivated. So supervised programs are definitely preferred if possible.
But if not possible,
Then self-directed home programs are the necessary alternative, and you can make them more effective. One study showed a home program boosted with lectures and weekly instruction significantly improved walking time. Another found that simply giving patients feedback, like using a step counter to track progress, led to adherence and improvements similar to a supervised program. So feedback and some structure are key even for home exercise.
now this is fascinating, the CLEVER trial. This directly compared exercise to stenting for blockages higher up in the aorta or iliac arteries. What did that show? This feels like a really important comparison.
It was a landmark trial, absolutely. The 6-month results came out in 2012. They took 111 patients with IC from aortoiliac disease and randomized them to optimal medical care alone, optimal medical care plus supervised exercise, or optimal medical care plus stent placement.
And the main outcome was walking time.
Yes, peak walking time on a treadmill test at 6 months. The results were really interesting.
Okay.
Supervised exercise plus medical care led to the greatest improvement in peak walking time, better than medical care alone and better than stenting plus medical care.
Wow. Exercise beats stenting for walking distance.
For peak walking time on the treadmill, yes. Stenting was also better than medical care alone, but exercise came out on top for that specific measure.
What about quality of life? Did patients feel better?
Both exercise and stenting improved quality of life measures more than medical care alone. But, and this is critical, the improvement in quality of life was actually greater for the stent group than for the exercise group.
So a bit of a mixed picture. Better walking with exercise, but better reported quality of life with stents.
Exactly. And cost-wise, as you'd expect, the intervention group was significantly more expensive than the supervised exercise group.
So the bottom line from CLEVER.
At that point, the data didn't show a clear winner. There was no compelling reason to definitively favor stents over supervised exercise for IC patients who were suitable for either therapy, especially considering the walking improvement with exercise. It really highlighted how powerful non-invasive therapy can be.
Okay, let's wrap up this section on non-interventional management. What's the big picture takeaway?
Sectional micro recap. Non-interventional management. It really boils down to this. Managing IC needs an individualized plan. You have to consider the patient's other health issues and what matters to them. Education is vital. Manage expectations, address amputation fears, emphasize the cardiovascular risk. Aggressive risk factor modification is the foundation, especially smoking cessation, grade 1A, and statins, grade 1A. Meds like salustazol can help symptoms, but exercise therapy is the true cornerstone, backed by strong evidence, level 1 for improving walking. Supervised programs are best, but well-structured home programs with feedback can work. And CLEVER showed us exercise can be as good or even better than stenting for improving walking distance, though stenting might yield higher QOL scores. The choice needs careful shared decision-making.
Great summary. Let's apply it one more time. 68-year-old male, lifestyle limiting claudication, got type 2 diabetes, controlled hypertension, but smokes a pack a day. ABI, it's 0.70. He really wants to walk better but is nervous about procedures. What's the most appropriate initial management strategy to discuss? A. Schedule an arteriogram for possible stenting. B. Start cilostazol immediately. C. Initiate a comprehensive program. Smoking cessation, optimized meds, statin antiplatelet BP control, and structured exercise. Or D. Reassure him amputation risk is low and just watch him.
Okay, lifestyle-limiting symptoms, smoker, diabetic, ABI 0.70, wants to avoid procedures initially.
Yep.
Arteriogram stenting is not the initial step. D, just watching is insufficient, especially since he's smoking. B, cilostazol could be part of the plan, but it's not the whole initial strategy. The clear best initial approach, hitting all the foundational elements the guidelines stress, is C. That comprehensive program, smoking cessation, get the meds optimized, and start a structured exercise program. That addresses everything up front before considering anything invasive.
Exactly right. Build that non-interventional foundation first.
Initial deep dive, epidemiology, diagnosis, non-interventional management.
So if we pull way back and look at everything we've covered in this initial deep dive into the SVS guidelines, it really paints a comprehensive picture. We started with the epidemiology, recognizing PAE is a huge, growing global problem, driven primarily by aging, smoking, and diabetes, with massive economic costs. Then diagnosis. The ABI is our key tool, but broad screening isn't quite there yet. A meticulous history and physical are crucial to rule out mimics, and things like TBI and exercise ABI help in tricky cases. Advanced imaging, reserved only for planning revascularisation.
Right.
For asymptomatic PAD, the mantra is aggressive risk factor modification, especially smoking cessation, and actively avoiding unnecessary interventions.
And for claudication.
For symptomatic intermittent claudication, it's all about that comprehensive non-interventional strategy first. Individualized approach, patient education, managing fear, setting goals, hitting risk factors hard, smoking, lipids, BP, considering meds like cilostazol, but absolutely prioritizing exercise therapy. Supervised is ideal, but structured home programs work too. And the CLEVER trial really drove home just how effective exercise can be, even compared to stents, for improving function.
It really lays out a clear evidence-based pathway. Outro. And that brings us to the end of the first part of our deep dive into these really important SVS guidelines. We've covered a lot of ground: the scope, the epidemiology, the diagnostics, and these robust non-interventional strategies for claudication.
Yeah, and I think the key takeaway is that while amputation risk in simple claudication is low, the impact on quality of life, and more importantly, the underlying systemic cardiovascular risk, are incredibly high. Mastering these foundational elements from diagnoses through lifestyle and exercise is how we can best guide our patients.
Absolutely. Which leaves us with a really interesting question to ponder, doesn't it? If these non-interventional therapies, especially optimized exercise, can be so effective functionally and often align better with what patients want, when does the scale tip towards revascularization? What are the nuances and considerations for those invasive procedures?
It's a critical question.
And we'll save that discussion, that next level of detail, for our next deep dive. So thank you for joining us on the deep dive. We hope this has given you a clear, practical, and valuable understanding of these crucial guidelines. Keep learning, keep questioning.
And we'll catch you next time.